who is chair of andLINFA, the Portuguese association caring for lymphedema and lipedema patients. And we have also from Lipedema UK, Kate Foster and Sherry Fetzer. By the way, happy birthday, Sherry. So thanks again for appreciating our webinars to raise awareness on lipedema. Thank you also to all the people who are joining our Facebook page, because we have a Facebook page gathering together all the association members for lipedema. It's an advocacy page, so we have a lot of people joining the page with their statements and pictures to inspire other people and other patients to take good care of themselves and of their lipedema. So just give me just some little moments to thank all our donors that made this possible, because all the compression garners producers who decided to support us, we have Uso Italia, Solidea, Varisan CZ, and also Medi UK. All these people maybe will stay with us for a long time, and they promised also to be involved in some more events in the future about compression and lipedema. But tonight we would like to extend a very, very special thanks to Human Med, who is one of our platinum donors for these webinars. And so they produce the technology of the water-assisted liposuction, about which we're going to speak in about some few minutes. So tonight we have the honor and the pleasure to present Dr. Burgos de la Obra from Spain. Marcella, would you please introduce our guest?
Yeah, it's a joy. Very welcome on my side too. Just few words to present Dr. Burgos de la Obra. Everybody that has already contact or information about our lipedema world surely already know his name, and it's double happy to see him today with us. Just few words. Dr. Burgos de la Obra is medical director and chief surgeon of Lipemedical, and he was the first Spanish surgeon to devote himself exclusively to lipedema treatment, using and developing the wall technique, and is one of the pioneers in treating this medical condition. He is currently the head of lipedemical team, coordinating a group of surgeons dedicated to the treatment of lipedema. In Lipemedical, they are proud to count on a European reference in the diagnosis and treatments of this clinical entity. I don't want to say too much about him. I am sure you will know him better with his own words right now, and for sure, for interest, visiting and meeting him personally in Madrid, Spain. But now the word is to Dr. Burgos de la Obra. The stage is yours.
Thank you very much. I'm gonna help you both for inviting me, for organizing this event. I'm sure we're gonna discuss very interesting ideas. I'm very happy to be with you today, and I'm gonna try to speak slowly so we can do the proper translation in
Thank
Italian.
you. Thank you.
And I wanna make like few ideas, but very clear ideas. So we also have time for questions and to solve everybody's doubt about lipedema treatment, about what it involves to go through the surgery, when to undergo surgery or not, because there's clear indications. And let's get started then when you
Okay.
when you
Thank
tell
you.
me.
Good
So
luck. Thank you very much.
all right, we share the screen then. Let me see. Fantastic. All right. Do you see the screen well? I'm not sure if...
I confirm.
Is it working?
Yes, yes.
Yes? All right. So I'm all right. And the voice and everything. All right. So we're going to speak about the lipedema journey and what to expect in intermediate and advanced cases. We're going to start with an initial question. So how many doctors in the world know what lipedema is? Just take a minute to answer yourself. It would be more than 30%, 30 to 10%, 10 to 3%, or less than 3%. Just choose one of the options. And I'm not sure which answer is this, but I'm very convinced that it's less than 3% of the doctors, of the overall doctors, GP, neurologists, cardiologists, vascular surgeons, pediatric doctors. And this is the main issue, that this condition is not known. And that's going to make that the patient's going to go through a lot of years, decades with this medical condition progressing and arriving to those intermediate and advanced cases. In the ideal situation, we should have never arrived to this, especially advanced cases. We should have diagnosed and treat this from the very beginning. But the situation now in the world, I guess, even in Europe, US, Canada, etc., is that is very little known, and that makes that the patients, they stay decades without diagnosis. We're going to speak about that in a little minute. So before we start, some of our patients, they gave us permission to reproduce them in our presentation. So I asked everybody to not reproduce it without permission. All right, so we're gonna introduce slightly our team. We have exclusive dedication to the diagnosis and treatment of symptomatic lipedema. This means that we are not treating any other condition, we are not treating any other kind of surgery, and we are not treating any other kind of patients that those with lipedema, with symptomatic lipedema. We are very focused in that. So we don't do breast surgery, we don't do abdominoplasty kind of surgery, we don't do a skin lift. We're like super specialized in lipedema liposuction of arms and legs. In our case, the 60% of our patients are international, increasingly more and more from Italy. I'm going to speak a little bit slower so we can get the translation well. So 16% of international patients, we undertake between 15 and 20 lipedema surgeries per week, and we are increasing this volume. And we see between 1,500 to 2,000 patients per year at consultation. That means that a lot of the patients that we see at consultation, they don't have lipedema, and we are very clear about it, or they do have lipedema, but the indication is not surgical. Would be an initial indication would be conservative indication. Here's our social media. We have also TikTok, and we're starting with that, in where we try to raise a lot of awareness to speak about this condition from the very medical point of view. Of course, Instagram is a photo platform, so we see befores and afters, but we try to focus a lot in the situation that this is a medical condition, and the aesthetic gain, it's a side effect, but the main goal is a medical one. All right. So in our consultation, this might be a very dramatic picture, but it's how many patients feel after long years of not having been heard, wrong diagnosis, misdiagnosis, and a lot of visits here and there to get an answer. So what do we need to know in an intermediate and advanced case? First, when we start the consultation, of course, we're gonna write down all the previous conditions, allergies, etc. But we're gonna put a lot of emphasis in the symptoms. If these symptoms are mild, or if these symptoms are intense or very intense. Please note that the symptoms and the grade, they don't run parallel. That means that very early grades can have a lot of symptoms, not allowing them to sleep, and very advanced cases may have just some mild heaviness. All right, so it's not equal advanced case with a very symptomatic patient. So I'm going to ask if the patient has a continuous heaviness, if there's hypersensitivity to touch, there's specific areas that we're gonna look for. If any GP is watching this presentation, we're gonna make clear where is the starting point where the pain starts, and sometimes these symptoms progress and the patient have pain at rest. And the worst case scenario is that the pain that interferes with the sleep, and this pain doesn't allow the patient to rest properly and interferes in her daily life. Of course, there's a great deal of implications in this pain if the diagnosis has been wrong. So they get a lot of remedies which just work partially, just painkillers or MLDs every now and then. And this is a very important sentence. The patient with lipedema, even with stage 2 or stage 3, has normalized the symptoms. So she's been with the symptoms from many years, decades, all her life, and she's not aware that she's having these symptoms. So she feels that this heaviness is normal, that the sensitivity to touch, or everybody feeling that she's very exaggerated, is normal. And it's not after a diagnosis that she opens her eyes and gets to know that this is not normal. Or sometimes once we finish the treatment, she starts to be aware of how much pain she used to have. All right. We need to ask a lot about the response to conventional measures. Has a patient tried hypocaloric diets? Has she tried exercise? Is there a response? The response is very limited. Usually there's some response, but it's usually very limited, and it rebounds back. So she tries. Sometimes they lose a lot of volume in the torso. And one of the features of lipedema is that there's disproportion between the torso and the legs. What happens with some intermediate case that starts to do exercise, starts to do a lot of different diets, she starts to lose weight from the torso. Therefore, the legs start to point out more. So she becomes even more disproportionate, and that is very frustrating, and that's gonna have a great impact in her mood. And very frequently, intermediate and advanced cases have tried many treatments. Sometimes they come with a shopping list of treatments of carboxytherapy, presotherapy, any therapy you can think about, and they've tried it, and maybe it partially worked, but then rebounds and back to pain and to non-response to exercise. Mobility. This is quite an issue in advanced cases. Of course, there's going to be limitation of the activity. We need to know that the patients with lipedema is not that they are lazy, is that they are, in fact, many of these patients, they make much more efforts compared to patients that have no lipedema to try to exercise, to try to work out, to try to walk. But the thing is that they're limited, first with the pain, second with the friction of the thighs, for example, and third with that heaviness that interferes with the way of walking. So there's also an impact in the way as a patient walks. For example, the inner part of the thighs with the volume, it's going to help that combined with some hypermobility that many patients have, it's going to produce a legs in X. So if you see a central photo of a patient that has no operation, you may see that the legs sometimes start to appear as an X, especially if the case is advanced. And in extreme cases, and we don't see many of these, some patients have arrived to the consultation with a wheelchair. It's just the end point of this is usually the end point in advanced ages, 65 or so, but it's been described in the literature, and I've seen 3 or 4 cases like this. All right, and we are at a consultation. We need to assess the physical symptoms, but we need to assess the psychological and emotional impact, especially if the case is advanced, because these cases have suffered a big deal, and they're usually not understood even by the near family or the husband, the partner. So they've been justifying themselves for a long time. So we ask directly, is there anxiety symptoms? Is there depressive symptoms? We need to know that around 10 to 15% of the cases, the advanced cases that we see at consultation, they have had eating disorders, mainly because this starts in a very difficult age, the teen age, usually the puberty, and it's a very vulnerable time, and that impact is going to stay for a very long period of time. So we need to ask specifically about the implications from the emotional and psychological point of view of these cases. Some of them, even they're very, very affected. Maybe the first step would not be surgery, conservative treatment, would be a psychological help to just to explain to someone how much they have suffered for many years, how they feel about it, how they feel about finally getting a diagnosis and knowing that the fault was not theirs. So it's something that we need to be very focused about, and we need to ask specifically. So for all these questions and for the in addition to the examination plus the explanation of the surgery plus the explanation of the conservative measures, is it enough with a consultation of 10, 15 minutes, 20 minutes? In our opinion, it's not possible to do it in that short time. At least a consultation of lipedema needs 40, 45, many times 60 minutes of listening, asking a lot of details about symptoms, implications in all the aspects of the patient's life, especially if it's an advanced case, and to examine it properly to see which areas are painful, affected, if the arms are affected, to give a very detailed explanation of what is going to be, how is going to be the surgery. Sorry for my English. It's how it's going to be the surgery, because many patients, they feel that this surgery is just something easy. And it's, especially in advanced cases, this surgery is going to have a very big impact. They're going to feel very tired. They're going to feel they're going to need help of their family, because we're going to remove big volumes of fat. We're going to speak about that in a minute. So in our case, we do two types of consultation: in-person consultation, but we have also developed, due to COVID situation, we developed an online protocol, which is working fantastically well. Indeed, many patients from Spain, they don't come to Madrid, they do the online consultation. And we in that consultation, we first set the reach the diagnosis or the no diagnosis, explain the options of treatment, and solve the doubts, which are usually very long list of doubts. So this is for GPs. Is the diagnosis always simple? So there's cases like one on the left, you see super clear, very truncular, the abdomen is very skinny, the feet are unaffected. Earlier case, that are the 2 points where you feel that a case where you should look for the pain. So those two areas is where the pain starts. So if you're not sure if this is lipedema or overweight, please touch on the pinch those areas, because you're gonna see that those areas are much more sensitive. On the right one, we see a case. The right slide, we see a case in which the clearness of the diagnosis is not that simple. So we always look for pain. Overweight is not painful. Obesity is not painful. Lymphedema, it's painless also. So pain is one of the main features, also disproportion, etc. But we need to know that what happens when a patient has stage 3 or stage 2 and associate overweight, because one of the features is disproportion. But what if she, in addition to lipedema, she has overweight? So first we need to ask what appears first. What frequently happens in these cases is that the patient, they have volume in the legs, they start to reduce their activity, they're not able to work out, they start to have more and more pain. So then they gain volume, and they gain volume in other areas. So first was the lipedema, and afterwards it came the overweight and the obesity. We need to ask how they have responded to previous loss. If indeed the torso, did it respond, or the legs, did they respond? Usually the torso tends to respond quite much, and the legs, the response is very, very little to hypocaloric diets. Is there pain? As we said, like that is one of the main features, that you just sometimes you pinch very, very softly and the patient, she jumps. So obesity or overweight is not painful. Just get that sentence. I guess it's one of the most important parts of this presentation. And in cases when there's a big, an important obesity and also associated lipedema, should we go for like lipedema surgery, or might be a good option to choose some bariatric surgery, some nutritional assessment? It really depends on the case. It depends on the team. Usually, in our case, above 140 kilograms, we usually ask the patients to try to at least try for 3-4 months to lose some volume, to lose some, so with some assessed with some help, to lose general volume in order to face the surgery in the best possible conditions. Knowing that sometimes it's feasible, sometimes it's just impossible for them. All right. Also, it's sometimes a little bit more difficult in cases that have previous surgery, and this is very frequent. Like up to, let's say, 25% of our patients, they have had previous liposuctions, usually very limited liposuctions, when the surgeon just remove here and there, just aesthetically, let's go out of here, and there's not a big reduction in pain, but sometimes, especially if you don't see many cases of lipedema, the diagnosis might be tricky. I'm going to try to speak a little bit slower for the translation. So, if there's been liposuctions, that in advanced cases there's frequently been, we need to ask what type was used, if it was like a common liposuction, or it was a wall liposuction, tumescent liposuction, which areas were they treated, how many liters were they removed, were there post-operative complications, and were there symptoms before this liposuction, how did they change these symptoms, was there effective? Usually there's some effect if they have reduced some volume, but sometimes there's absolutely no effect of a previous liposuction of 2 liters or 3 liters in an advanced case, in which we ourselves, we would remove 9-10 liters per surgery and then do 3 surgeries. So so here's a very clear vision of the difference between grades and types of lipedema, because sometimes some people mix it up. Grades or degree, it's how much it is. Type is where it is. You see, normal case, stage 1, stage 2, stage 3 is just a picture. The thing is that sometimes with the types, there's some difference depending on the classification. All right, so here you see that the type 1, type 2, type 3 is more or less the same, but for the type 4 and 5, there's difference between some classification. For example, the single classification, the type 3 is a lipolymphedema. In the Mayer-Borath classification, it's legs affected, but only from knee to ankle. So it's something that it still need to be that the community needs to work on, because we need to be a little bit more clear with this. Here you see another picture where it shows the difference between stage. You see initial stage, stage 2, stage 3, and the type. Type 1 mostly proximal affectation, type 2 from waist to the knees, type 3 all of the legs. In this classification, type 4 just the proximal arm, type 5 the distal legs. All right, so how a patient with lipedema reach stage 3, which is something that should never be reached, no? In Spain, a study was made and to know what was the average time that a patient takes for getting a diagnosis and how many doctors she has visited before getting a diagnosis. All right. Sometimes in my consultation, I've seen patients with 10 or 12 doctors, and the results were like this: 20 years, 20, I would say 20 years since the symptoms began till they got the diagnosis, and around 5 medical visits for a patient to reach a diagnosis. It's just unbelievable, and it should not be happening. Again, I go to this. Please note that the lipedema prevalence, and this is a conservative number, it's around 4%, sometimes 11%. And almost nobody knows about it. You know what is the prevalence of diabetes type 2 in type 1 in the world is 0.2, and everybody know about it. So awareness, so we can never reach an advanced case. And also, there's a thing that you would think, all right, the doctors don't know about this because it has been described very recently, no? So this is the first article about lipedema where we see the photographs, we see the differential diagnosis with lymphedema. So what year do you think this was published? 2000, 995? No, this was the date. So it's almost 82 years ago, and it's quite a lot for not knowing about this. So it has been described for a long period of time. We need to know, or everybody they need to learn about that this exists. All right, so let's go for the treatment part. I guess you're more interested in. So does conservative management works in advanced cases? It's a tricky question. First, we speak about which are these conservative measurements. First, mainly 3: the conservative, the flat knit compression used has to be flat knit, tailor-made from, in my opinion, from waist to the feet, and at least 20-30 milligrams of pressure. Aquagym, aquabike, swimming is going to help quite a lot, specifically aquabike because the legs are a little bit more deep. And the anti-inflammatory nutrition is going to help a great deal in helping with, that's going to consist in avoid dairy products, red meat, refined carbs, gluten specifically, increased nuts, berries, citric foods, etc., and some other words that I don't know in English, but everybody knows about this. In a stage 3 with a lot of pain, is it going to work? I would say it's going to work in many cases, but the impact sometimes it's going to be limited, or sometimes is, let's say, it's not going to be enough for the patient. So this is something we're gonna need to ask about. How much a patient with advanced case or intermediate case has he tried this? Has he properly tried? Has he worn the compression? Has he done the anti-inflammatory diet? Has he did the aquagym options, etc.? Many times they tried for 2 years and the change was minimal, or other times the change was like at 20, 30, 40% improvement, but that's not enough. So in my opinion, every patient should know about the conservative measurements, but after a certain period of time when it didn't work, it hasn't worked, and the patient is very frustrated, then operation should be an option we need to consider. All right. Also, we need to know about the tolerance of compression. So we get a lot of patients from Middle East from South America, from the south of Spain, or even in cold countries that they've tried the compression and they are not, they cannot tolerate it. You ask a patient to wear the compression for all her life, and they look at you like saying like, no way. So I'd rather choose operation, go through that for the period that it's needed, but I'm not wearing this for life. All right. And one of the objectives of the operation is to be able to at least need as less as possible the compression, or in many cases not to need the compression. So we need to ask in detail, what is the affectation, the impact in the daily life? You know what, Dr. Burgos? Absolutely no impact, normal life. I have some volume, yes, some aesthetic concern, not much going on from the symptoms point of view. I would say better not to operate, better to do a follow-up and see how this goes. Try the conservative measurements, see how you react to that. In case of doubt, my advice is not to operate. It's better to try the conservative measurements, see each other again in 6 to 12 months, see what has happened. All right. And sometimes what happens is that the patient was used to the pain, as we spoke about. She normalized the symptoms. You put the compression, you put all the measurements, and the pain goes down. So they start to be aware that they have pain and how much big deal of pain they have. So now, okay, I've improved, but I want surgery anyhow. Is there any urgent indication in lipedema? No. Don't trust anybody that go fast to a lipedema surgery. There's no, in my opinion, there's no urgent indication. This is an important surgery that needs to be think about, that you need to know about the team that is going to perform it, if the indication is clear, if you tried or not tried the conservative approach, and it's nothing to rush about. So take your time to decide, take your time to see cases and to know what the surgery is about. So the key of operating is to individualize the treatment. I cannot give like rules. I have to see or my team has to see each of the patients to decide if the surgery, the benefit risk of the surgery, it's in favor of the surgery. So what do we look for with the surgery? What we're gonna do is we're gonna remove big volumes of fat that in advanced cases, as I said, can be like very high, above 5 liters per surgery. It's quite a surgery, but sometimes we reach 7, 8, 9, 10, even in a case 12. And we're gonna look for a big volume removal and with techniques that respect the lymphatic vessels. In my opinion, the wall technique with the Human device is the adequate technique for this, because it's going to respect the lymphatic vessels. It's going to be very delicate with the skin, with the structures, and it's going to help to the patient to recover faster with like the best possible result. Because in my opinion, as a surgeon or as a surgical team, you need to look for the best possible result within safety. All right. So it doesn't make sense to just do something here and there and leave. Every patient needs the time that she needs. And if it not can be done in one surgery, 2 surgeries or 3 surgeries, but the aim is to leave the perfect layer so that as the pain, the symptoms, they don't come back. So that's going to imply that an advanced case is going to need a big volume removal, and it's going to be an intense post-operative period. All right. By the way, the part that we count is just the fat. It's not the liquid that we put in. It's just the fat. So what are the objectives, in my opinion, for lipedema surgery? The main objective, and this is super important, the main objective of lipedema surgery is a medical objective, meaning to treat the symptoms, to reduce the pain, the heaviness, to improve the mobility, so the patient, they can start to do exercise for the first time on their life. In advanced cases, for example, has happened very frequently, that they suddenly finish the treatment and they are able to run, for example, and to stop the progression, or at least to slow the progression, or to do as much as we can so the situation is reset to the first grade, or not to the first, to the before the first grade. All right, and that's going to need a lot of volume removal, and that's going to need a lot of ambition from the surgical point of view to get that result of controlling the how long we're going to control it. We're not sure about that, but at least let's do the effort to control it as much as possible. Instead of aesthetic results, I prefer to speak about anatomical results, because with the surgery, what we're gonna do is we're gonna restore the normal anatomy, the knee that has lost its shape, the ankle that has lost its shape, etc. All right, and in advanced cases, in intermediate and advanced cases, that's gonna have some implications because when we remove a lot of volume, of course, the skin is going to react to that. And the best measure for the skin to react is to wait and to swim. But of course, if we're going to change a leg, which is like this, to this, even if we stimulate the skin for natural retraction, the thighs, sometimes they don't have much capacity. So we need to count on some looseness. Depends on the case, more or less, but we need to count on that looseness and speak about it clearly in the consultation. So this is a very frequent question that the patient asks: how much you're going to take me out? The question is not how much you're going to take me out, is how much is going to stay. And the aim is that this fat layer should be like the perfect fat layer for safety, female shape, and symptoms control. All right, so do not compare yourself to other patients in terms of volume. A volume of a surgery of 4 liters is not better than a surgery of 3 liters. Every patient needs to be removed the amount that she needs. Of course, in advanced cases, usually the volume that we remove, it's going to be very high. All right. Limits. What is the limit of volume? In my opinion, more than reasonable limit, and its limit is 10% of the body weight. Meaning, if you are 110 kilograms, more than 11 liters removed per surgery is going to be too much. All right, and it's, in my opinion, it's not going to be safe. We frequently stay between 6% and 8%, but we can reach up to 10%. And also, we need to count on the opinion of the patient, because sometimes they have a specific preference, for example, for the gluteal area, and we respect them. All right. So, how is the postoperative period for an advanced case? It's hard and tired. It's hard and tired. And it's like this, all right? You cannot expect to be removed 11 liters or 10 liters or 5 or 6 liters, which is, again, 5 to 6 liters. It's quite a lot in some cases, specifically above 45 years old. And you're going to feel especially weak, all right? So for the first 10 days, you're going to feel quite weak. You're going to go to the toilet, go to the kitchen. I'm lacking like of soul. And it's very frequent that the patient, they stay for some days, and then it's like very inappetent. They feel that they are lacking of energy for some days. All right. In my opinion, this surgery should be done in hospitals, not in clinics with less resources. And in hospitals, because there's an intensive care unit, we don't use it, but it's good to know that there's an intensive care unit there. And also with the blood bank, again, the possibility of transfusion is very low, usually below 1-2% of the cases, but it's also good that there's a presence of the blood bank in the hospital. All right. So plus there's many other specialists if you get any other problem. So in my opinion, choose a place which is a hospital, not a clinic with 10 beds, but a hospital with 50, 60, 100 beds. All right. In terms of prevention of complications, which are mainly tiredness, skin issues, thrombosis, etc., we, of course, this is very detailedly explained in each of the consultations, but what we need to know that the compression and the lymphatic drainage postoperatively, they're going to be crucial. They're going to reduce the pressure. They're going to feel the patient improve in all aspects. They're going to sleep better. They're going to feel better. They're going to ask for less painkillers, all right? It's super important to the compliance with the recommendation. Some patients, we ask for heparin to all our patients, and some of them confess that sometimes they forget one of two syringes. Please get the compliance with the recommendation. And also a close monitoring. So it's very important that the monitoring is both from the physical and the emotional point of view. I think one of the things that define us as a medical group is, as we only treat this condition, we are like super aware of what's going to happen in the postoperative period in terms of emotions, and we like to be there, and there's a specific person at the disposal of each of the patients to know how the patient is feeling, to explaining what is normal and what's not normal. The patients always have the phone of their surgeon in case they need anything. So a close monitoring is key. It's not just operation and gone. It has to be specifically the first 10 days. We need to be very, very close and to speak a lot. All right, we're going to see some photos of let me see how we're going with the time. I think it's fine. Before, after, many of you have seen a lot about this. The photos, they attract a lot of attention. They're very like visual impact, etc. But let's keep in mind that the important thing is the absence of continuous heaviness, the disappearance of the pain, the increase of the mobility, the restart of the physical activity, or sometimes, as we said, to start the activity for the first time in your life, to slow or to stop the progression, to be a mood boost for a new lifestyle. And maybe many of you will see many cases that they even run marathons, or they not just run marathons, but they sometimes they start going to physical activities in groups. The psychological change is huge in an intermediate and advanced case, much more than in an early stage. So we're gonna see that in an advanced case, there's gonna be a huge change in that. And of course, the marked improvement in quality of life. Also, I get asked a lot, why don't I post many patients stage 3? The thing is that stage 3 patients, as we spoke, they have suffered a lot. They usually don't like to post their photographs. They don't like to expose themselves. That's why stages 1 and stages 2 are very likely to post them, but the advanced stages are very reluctant to post their results, because they don't want to be exposed to the others' opinions, which is very respectable. Okay, let's see some photographs. This is 110 kilograms. I post this also on the social media recently. You see some of the wrinkles. We always mark the wrinkles because the wrinkles, they're going to be more visible after the treatment. All right, and here we see how the situation has changed completely. The way of walking has changed completely. The wrinkles we marked, they become more visible as we spoke, and also she's been able to lose some more volume of the abdomen, because that's the idea. Once you start once you treat the legs, also on the long term, not for a year or a year and a half, for a year and a half, you're gonna feel that this is bigger, because it's gonna point out much more. So be aware of that. But after that, 1 year and a half after surgery, everything's gonna normalize much more, and the patient's gonna be able to exercise, and this is gonna be able to lose some volume here. So this is one of the big changes. Little bit more here. The age, it's a very, very, very important factor in lipedema surgery. Above 40, 45 years old, 50 years old, the evolution of the patient is going to be much slower, because everything gets very swollen. The feet gets very swollen. Everything is super uncomfortable. The stage 3 looks for a patient to compare herself with. There's nobody, because all the stages that are posted are stage 1 and stage 2. They get super frustrated, super anxious, and that's very frequent. That the patient, they get very nervous. the change will arrive, but instead of needing 6, 9, 12 months, maybe she needs 9, 12, 15, 18 months. All right, here's the difference. In this case, 52 years old, you see how the skin has responded quite well. There's not always looseness with the stimulation of the skin. We see how sometimes they react very well. Of course, it's 52 years old. There's some wrinkles, but imagine the new feeling of this patient, how she feels now while exercising, or how she feels now like when walking with her husband, just going for a walk, for example. A very truncular case, a lot of volume, young patient, a very deep psychological, emotional impact, and we've restored the anatomy. We have gotten rid of the pain. We see how we have restored the ankles. We've restored the knees. Now this is a completely different person, not just from the physical point of view, but also from the emotional and psychological point of view. Look at this case. This is a case that she already had a previous surgery. See that there's a big difference between one leg and the other one. In certain cases, instead of starting in the lower legs, if there's a lot of volume in the thighs, we start in the thighs. So that is going to make the patient to gain some mobility and to lose even more weight to address the lower legs. So in this specific case, we did the opposite way around as we used to do. So you see that we remove a lot of volume from the thighs in 2 surgeries, a little bit already in that leg to try to equalize as much as possible. See the wrinkles that, of course, at first they're going to be very present, and with time it's going to improve. With swimming, it's going to improve. With radio frequency, is going to improve. And certain cases, or certain advanced or very advanced cases, they're going to need a thigh lift. We usually tell the patient in advance who are more likely to need this skin surgery. All right. Okay, and this is the end point. All right, we see how we have recovered. The legs are not absolutely identical in size, but we have improved or reduced a lot of that difference. See how the skin has started to react, how started to not absolutely to normal, but has reacted quite a lot and still has a lot of margin of improvement. I always say to my patient that we need to, for the final result in terms of skin, we need to wait at least a year and a half, or sometimes even more in a very advanced case. So very happy about the mobility, very happy about the pain, plus the anatomic results. But this patient, the first 5-6 sentences of the consultation were about pain-free life, mobility, exercise, quality of life. At the end, she was also saying, and also I look better for myself. I bought different new clothes, etc. But that was not the main goal, and this is super important to speak about. This more intermediate case, we'll go through it because this is more intermediate and this more initial intermediate, but also we see how there's like a regain in shape, and you see the hematomas that are usually very frequent in lipedema that they have disappeared. So what to expect in the long term? Let's see how we go with the time. I think it's fine. Symptomatology, we're going to look for a relief. It's going to be the most pronounced word. Mobility, etc. We're not going to repeat much. Skin flaccidity, we already spoke about this in advanced degrees, and also we need to know other factors such as age, mainly. Previous looseness. So there's patients that they have lost a lot, and the skin has already made a lot of effort, and then they need like an extra effort. All right, so that's gonna make the skin to react less. Some treatments we spoke about aqua gym, radio frequency. There's some devices, G plasma, Renubion, etc. In my opinion, most of that therapies are not needed, and it's, in my opinion, is not a good idea to do it at the same time as the lipedema surgery. It's good to do it if they are needed in a second time, because most of the times they're not needed. So the patient is paying more, longer surgery, and not much need for that if the technique was good and we wait enough. All right, but sometimes some patients, they do need them, but if they need it, most probably what they need really is a skin lift, most probably. We need to know that there's possible growth in other areas, specifically the arms. As we spoke in recently on social media, there's 3 factors involved. First, the lipedema in arms is going its own pace. Second, I do feel that when you remove a lot of volume, the arms react somehow. The fat of the arms react somehow. It might increase a little bit. And third, visually, when the patient sees herself in the mirror, if she's much thinner in the legs, the arms are gonna, with a dress, for example, they're gonna point out much more. Let's talk about advanced lipedema in the arms. It's usually less painful. Main concern is the heaviness. This is especially important in cases where the patient is like a hairdresser or a teacher, for example, that she feels very heavy the arms. There's a lot of sensitiveness to touch, tendency to bruise less than the legs, but also present. And also in the physical examination, this is the point where it's usually more painful. This is the point. Just in case you don't know if you have or not lipedema signs, pinch yourself in the belly, see if that pressure is much or not. If it's painful, usually it's not. And then you compare with the same pressure here, and you may feel the pinch has to be a small pinch, not big pinch. So this is not the proper pinch. This is the proper pinch. So the surgical indication for an advanced case also in arms is to individualize. We need to be aware that the surgery is a little bit more complex. If you are having surgery of lipedema of arms, please find for a specialist in this. All right, do not go to a surgeon that does breast, abdominoplasty, eyelids, and sometimes does lipedema, and very rarely does lipedema in arms. For lipedema in arms, please choose someone that has a lot of volume and a lot of experience with this, and see if he has already shown his results. More complex surgeries, because there's a lot of details: the armpit, the flexor, the elbow, the wrist. So and that's my advice to find for someone like very specialized. And I'm going to try to accelerate a little bit more. The postoperative period is less tired. It's a little bit uncomfortable for the day-to-day, the first week, especially if you have children. You need to rest a little bit. You need some help. There's going to be some hand edema. We need also crucial compression and not drains, manual MLDs. And concerning looseness, the looseness, if it's going to be found, is going to be here. And we find that when we do circumferential approach, stimulating the skin, we feel that very few cases need an arm lift. All right, you may have seen some. I don't have here today an advanced case, but maybe you've seen some of our case in the social media, and you see that how the skin reacts a lot. All right, so sometimes it's needed if it's a very advanced case or if the muscle is very small, but usually it's not needed. I'm gonna try to look for seeing again the muscle anatomy. The patient is gonna feel much more light, and she's gonna gain much more mobility, especially if in her work he uses a lot the arms. Anatomical result, here we see she didn't work out anything. We just removed the fat, and that was the muscle that was below there. All right, she's been exercising for many years, no result, a lot of frustration, anger, and we do the surgery, and what was just beneath was quite a muscular arm. I'm ending with what's the role of the family. The family is super important, like super important. Family, partner, etc. The one that surrounds the patient in this process is super important, and they should be involved from the beginning, meaning bring them to the consultation or bring them to the online consultation. Let them hear what is your condition. Let them hear what you're gonna go through, because they're gonna help you a lot. Just not just but with emotional support, which is super important, but mobility aid, the first times to stand up, etc., and to move. So bring them to the consultation, so they know what you have suffered. They know, so they can know that this is a disease, and it's not the same if they hear it from a doctor that if they hear it from yourself. So bring it to the consultation wherever you consultation you do. And a big important message: surgery and that's it. Specifically in an intermediate and advanced cases, lipedema surgery is not the end of the road, but should be the beginning of a new lifestyle. This is a sentence that I've said many times. We need to use that momentum to incorporate the sports in our daily life. We need to be very attentive to keep a healthy lifestyle, healthy nutrition, and to use that for changing completely our life. So surgery is not the last the part of the road, is the beginning of a new road. The final message, that patients that with advanced cases have already suffered a lot when they come to our consultation. We need to hear them. We need to explain in detail what this is all about. All the impact on our patient daily lives must be actively evaluated. This needs time, 45 minutes at least, to establish the correct indication and to be able to say no to a patient. It's something good, all right? So we need to accept when a surgeon tells you, wait, let's try conservative measurements 6 weeks. Let's see how it goes, and then we decide, all right? I know that sometimes everybody's very anxious to get surgery, but it's good always to think about it. There's no standard goal in terms of fat removal. I'm gonna get you out 4 liters, 3 liters. As answer is, I'm gonna remove the volume you need. That's the answer. The main goal of lipedema treatment in advanced, intermediate, in all cases, is to improve the quality of life and improve the progression. The results are never perfect. Social media sometimes might be misleading, and as I said, the initial and intermediate cases are the most posted. We need to expect some degrees of laxity in the thighs, and sometimes some small irregularities here and there, for sure. Small but present. Long-term studies suggest that the surgery is going to help with the symptoms control and slowing the progression. The family has a key role in recovery, and surgery is not the end of the road; it's the beginning of a new lifestyle. I want to finish with this image. This is an image of a patient that she sent us, representing how she was feeling after the whole surgical process, and yeah, she feels lighter. She feels more confident, and most important thing, she's painless right now. Here are our contact details. Our website. In our website, we have an area where we say what happens is if my GP doesn't know what lipedema is. There's I think it's 15 medical articles, 5 clinical guides, so you can print them and bring it to him, so he can not refuse to listen to you. Our email, if you would like to have a consultation, an online or in-person consultation with us, and our Instagram page is not my Instagram page, is representing the whole surgeons group results. Sometimes the patients are very obsessed with Dr. Burgos, and we are a team, and we work as a team. And yes, that's it. I'm gonna finish.
Thank you very much, Doctor.
Okay, I was not sure if I was speaking alone because I was. I had no feedback. So yeah, I'm glad that you hear everything. Let me get you.
Yes. So we have some questions for you from the audience, particularly about a super hot topic in lipedema surgeries regarding lipedema regrowth. So it's our patients sometimes are scared about the fact that after investing so much in lipedema surgery, it can worsen again or present itself in areas which didn't show the symptoms of lipedema. So lipedema regrowth is an issue that sometimes can scare the patients and prevent them from in starting the surgical path. So what is your experience about lipedema regrowth?
So concerning lipedema regrowth, we need to make the difference between two regrowths: the regrowth of an area that has been treated, or the not regrowth, or the growth in an area that has not been treated. In my opinion, if the surgery is ambitious, and if you are not just removing an intermediate volume, you're gonna go ambitiously to remove a lot of fat, knowing that the postoperative is gonna be tired, of course. And the remaining layer is gonna be very thin. The possibility of that thin layer to go back to the previous situation, it's minimal. Of course, we need a lot of long-term studies, but that's my opinion. Concerning other areas, we need to know that this is a whole medical condition. It's not a medical condition of the legs. It's a global medical condition. So that mainly affects arms and legs, right? So in the arms specifically, when there's already volume, when there's already symptoms, in my opinion, don't know the percentage, but maybe 10% of advanced cases may feel that after the surgery they get some volume in the arms. We need to also know that for sure the 6 to 9 months after surgery, the patient is going to gain weight, because if she has they have normal activity, which is 10-15,000 steps per day, they're going to go to 0, and then they're going to walk 100, 200, 1,000, 500. So they're going to get a lot of months till they recover back their activity. So it's normal that if you are usually active or more or less active and you have no activity for some time, you're going to gain weight in which areas? The areas that are not operated. So my advice is that for knowing if this is like a real growth or just a compensation, temporary compensation growth, we need to wait till the patient has recovered and started to do exercise. Because some patients, once we treat their legs, they gain a little bit of volume in the arms, but afterwards they start being able to exercise. And in my experience, the fat of the arms respond much better compared to the arms, to the fat of the legs.
You partly answered also to the second part of the question, because the second part of the question was your tips for lipedema patients to maintain the results they managed to get after the surgical path. So every lipi patient wants to do whatever she can to maintain these results as long as she can.
First, super important not to be eager to get the results. The results are gonna take time, and in an advanced case, a lot of time. Sometimes I feel that as the patient have been without diagnosis for many times, they are like super attentive to their legs. They're checking it measuring every day. Sometimes they send us like all of the measurements. It's also good to breathe a little bit after surgery, to get your own space, to rest a little bit from all the noise, and to try to little by little recover from the surgery and start to use that impulse, that momentum of the surgery to be able to exercise, to walk, to swim, etc. Plus, super important, the anti-inflammatory nutrition. But of course, there's other elements that we cannot control. For example, the hormonal element. So that's going to be there, and of course they're going to have some effect. So that's why we need also to do a follow-up, or at least to be readily available if the patient feels that maybe 3, 4, 5 years or 6 months after surgery they feel that they have more volume in the arms, to let's say, okay, let's treat them. Or sometimes the patient, they will reduce the volume on the legs, and then they become aware of what the pain is, and then they start to touch themselves and they, oof, I have pain here, but I didn't know about it.
Okay. And what about physiotherapy? What do you think? For example, we have some question about deep tissue massage or fascia massage, which is maybe more effective than the simple decongestive therapy or treatments taken from lymphology, or maybe those treatments should be integrated with new techniques that go deep into fascia and fibrosis. So we have a lot of questions about fibrosis management in lipedema and fighting fibrosis.
The fascia massage, the thing is that in lipedema in general, there are not clear recommendations or guidelines. So we, in other cases as diabetes, they took 1,000 patients and compared with another 1,000 patients. So everything or many treatments are very experimental. So some patients, they say it works for me, but some other patient, if you tell them do it, they say it's horrible. I would never try this. So it's we lack studies to know what's really effective or what is not. Honestly, I have very few experience with fascia blasting and those kind of therapies, so I cannot recommend something that I'm not familiar with in my daily practice. Mainly because I'm a surgeon. Most probably, if we have here a physiotherapist, maybe he or she can speak a little bit more about the advantages of that. But I'm very cautious in recommending things because when you recommend something, you're also responsible for that result of that something. And some commercial brands have pushed me very hard to recommend treatments that I'm gonna not name, and I pay you this and I pay you that if you and I say no, I cannot, because that's called experimenting and needs a certain rules, and the patient needs to know that you're experimenting. So little by little we get a little bit of more evidence, but I cannot answer you that because I'm not sure about it.
Informed consensus is a very big issue in the lipedema world because a lot of patients do not know that they're doing some trials and experimental research. They are not quietly informed. So thank you very much, Doctor, to raise awareness also on this specific topic, because patients must be informed anytime. Thank you. Marcella, do you have a question for the doctor from our audience?
Oh, yes. There is one question that I really like because in your experience, and you have a huge experience, how is the evolution after the OPs in the middle and long term?
All right. So in the long term, there's the thing is that there's just one study, or at least that I know, that reaches 12 years, which is the Baumgarten study. It says that after 12 years, there's a maintenance of the effect in terms of need of compressive therapy, in terms of relief, but it's a study with very few patients and with very super limited. So we cannot give we can give opinions about our experience or what we think. For example, I think in some like in the American guideline and in a German guideline also, one thing that they say is that do the surgery with high volume centers. That's something which is clear. There's a clear effect of the use of compression. That's very clear. But how long the result is going to last? 20 years, 30 years, 40? We still don't know about that because we lack data, and we lack we can gather data, but 10 years, more than 10, 15 years, it's not known. In my personal opinion, first thing is that the surgeon must be ambitious. If he's saying that he's going to remove an ambitious volume, he has to remove an ambitious volume, because very frequently I get patients that had liposuction and they just some removal, or the knee hasn't changed, or there's here and there. How many liters? 2 liters. But you're stage 3, yes, but it was 2 liters. So an advanced case needs an advanced approach, and that's going to help a lot to maintain the results. So also that is important, that for being able to say it's going to last for 20 years, you need to count with different surgeons. So, and it's difficult to compare a surgeon that removes 2 liters per surgery and that's it, or a surgeon that removes 5 liters and that's 3 surgeries to leave the perfect layer. In addition to this, it's super, super important. This is a teamwork. So part of the team is the medical team, part of the team is the patient and her environment, her partner. So she needs to use that effort. I stress this a lot, to keep exercising and to be very attentive to the nutrition. So because I had some cases that the patient, you do the surgery and it's like, as I have the surgery, poof, I can eat whatever and I can, I don't know. You need to be responsible also in this sense. So we need to work as a team to obtain a very long-term result.
Very powerful message.
Yes. Absolutely.
Marcella, you had some kind of question about the percentage of the amount.
Exactly. That's something that makes me really curious. On late stage, we have often very important body presence. And in your explanation, you said you prefer to stay under the 8% of the weight in the operation. So just to make a very easy mathematical calculation, in a very important late stage, how many OPs does a lady have to a person to plan?
I'm not sure if I understood the question. I'm going to answer something, but I'm
How
not
is
sure.
the steps? How can
The steps.
a patient can imagine the steps?
All right. So first, what we're going to do is we're going to assess a patient at consultation, see where's the affectation, because, for example, we have patients that the thighs are more or less reasonable, have responded well to conservative measurements, but the lower legs from ankle to knee, no response at all. And we remove 8 liters, for example. We assess the patient at consultation and we tell her, we draft a treatment plan, all right, which is usually 1, 2, or 3 surgeries for the legs, depending on the affectation. If the affectation goes from the ankles to the waist, in my opinion, 1 surgery to do it properly and to safely and with a long-term approach is not enough with 1 surgery. We need to split at least in 2. Sometimes you are not sure if the patient is going to need 2 or 3 surgeries. You just say it like this. Let's see how, we're going to start with the lower legs and see how the upper legs react. So it also a matter of muscle. So if the leg is like this, the muscle is like this, we have this fat layer. But if the leg is like this and the muscle is like that, we have a lot bigger fat layer. And the aim is that the fat layer is the perfect one. So sometimes we cannot anticipate how it's going to be. We need to be open about this. But usually advanced cases, like a proper advanced case, it usually needs 3 surgeries for the legs. Super advanced case might need 4, but that's something that is above 140 kilograms and 50, and a lot of attempts to try attempts to reduce volume and no volume reduction.
I understand. Thank you.
I have a couple of questions coming from the Lipedema UK socials. We have actually 2 different questions because how long before you can swim again after surgery?
All right. Okay. Ideally, as soon as possible, because the swimming, the pressure of the water is going to massage the legs and it's going to reduce the. In fact, there are some protocols that they put it very early, like 10 days after. The thing is that also we need to take into account that the incisions and some of the incisions are open, so we need at least some healing so we need to wait for some healing of them. So I would say that I used to say a month and a half. We are reducing this to 2 to 3 weeks or sometimes even less if the incisions are healed.
Okay. And the second question is about the management of patients with low blood pressure. How do you manage these people?
All right.
Because they
Okay. We need to
are-
assess the patient as a whole. All right. So, and we need to well balance risk and benefits. Many young patients have low blood pressure, but we need to know what is low pressure for a patient. If it's like mildly low or like super very low. So, what we usually do is count on the anesthesia team, so they can assess that patient and tell us how prepared or not is going to be for surgery. If the if she cannot stand a very intensive approach, maybe what we should do is to do a more intermediate approach or some more conservative approach in terms of surgery. So remove less volume, so we are able to get rid of the symptoms, improve her quality of life, but stay within reasonable risks.
Okay. And I have a question coming from Italy. How do you manage the international patients? Because a lot of Italian patients would like to come to Spain to
All
get
right.
their surgeries, but maybe they're scared of the language issue.
All
So
right.
how do you manage?
Okay.
Also, it's not just about Italians, but maybe people coming from England or people
Mhm.
coming from Portugal
Fantastic.
or
Well,
other
sure.
countries.
Okay, so I'm going to speak in general, and then I'll speak about the
Okay.
Italian
Thank you.
patient. So, concerning a general international patient, most of our patients are international now. So we have a specific, very clear protocol for this. We do usually, of course, we are open for an in-person consultation, and sometimes a patient gets a flight from Toronto, Madrid, and then back. But usually, it's much easier to have an online consultation if possible, because we need to know that online consultation are not okay for every case. We ask for we have a medical questionnaire of symptoms, etc., evolution and onset, etc. We ask for specific photographs to see if there's disproportion, but sometimes we are not sure about the indication, and if we are not sure about the indication, then we need the patient to come to Madrid. When a patient send us her pictures, specific ones that are very detailed of what we want to see, and the questionnaire, sometimes directly, especially if it's a very early stage, or if he has multiple previous liposuction, we tell her it's not possible to evaluate you online. You need to come directly. Sometimes we said it seems that it seems that it's lipedema. We're gonna have the consultation and we're gonna confirm it. All right, knowing more about from your words, we're gonna ask you to pinch yourself. We're gonna ask you a little bit more, and sometimes I would say like 70% of the cases, the symptoms, the photos, and everything is like super clear, like incredibly clear, very thin torso, very big volume, feet free of affectation, pain, tenderness to touch, everything matches. All right. So we do the online consultation. The blood test can be done should be usually are done back home. So, for example, in Rome, they do the blood test, the electrocardiogram, the Doppler ultrasound to check if there are varicose veins. They send it to us. They have the consultation online with the anesthesiologist, so they don't need to come in advance for the anesthesiologist. They will come for the surgery, have the surgery, staying one night at the hospital usually, and then they're going to stay for some days in Madrid receiving MLDs, like very specialized MLDs in very specific 3-4 centers that they have a lot of experience, and then they go back. Throughout all this period, they're going to have of course the phone of our nurse team and the phone of the surgeon. We all speak English, and half of the team speaks French also. There's one also on the team speaks Italian and French and German also. So yes, and they're going to be a close contact with us at the hospital. Mainly the language spoken is it's English. As what is needed is very basic. Sometimes we have Belarusian patients or Taiwanese patients, they have their their translator, the Google app. They just speak and it's spoken, speaking, spoken. So with the Italian patients that we've operated, and lately we have operated quite a lot, they do like this. Maybe we understand them because Spanish and Italian is very similar, but they use the translator. Or there's the doctor that of our team, which is Dr. Hernandez, that speaks perfect Italian, and also part of our administration teams speaks in Italian too.
Thank you very much. This is a very good news for our Italian patients caring about language issues and scared about this. So very, very good news. Thank you. And Marcella, do you have other questions?
Yes, a very interesting one. A lady asked, I am stage 4, discovered about a year ago that I have lipedema in all lower and upper extremities. Overpriced therapies and prescribed stockings I still did not purchase. What is the future without treatments? What is the future I should expect?
All right, so a stage 4 in some classifications is spoken as lipolymphedema. So I'm not sure if you're saying that she has lipedema plus lymphedema. When there's a very clear, there's a study in Spain that says that around 40% of the patients with lipedema, when they do a lymphography, there's some mild abnormalities of the functioning because of the pressure of the fat. But when there's like a clear established lymphedema, that case, the approach is not going to be a wall technique or a liposuction. The approach at first should be to consult with a lymphatic surgeon that's going to help her with maybe anastomosis with the lymphatic and the blood vessels, or with no transfer from the armpit to the needed area. So in our case, we do not treat lymphedema cases, lymphedema established cases. So my advice to her would be to consult with a lymphedema surgeon. There's Dr. Jay Grazno in the US. There's Dr. Jaume Macià in Barcelona, and both of these surgeons, they know how to treat lymphedema, and they also treat lipedema. So my advice is to try to find a specific lymphedema surgeon.
I have a question about the technique again, because you already spoke about water-assisted liposuction, but this person is asking, can you summarize the advantages of the water-assisted liposuction in comparison to other techniques such as power-assisted or laser-assisted or Vaser or whatever?
Right. In my opinion, and this is maybe a little bit controversial, energy should be avoided. Vaser and laser are not a good idea because, in my opinion, they can damage the lymphatic vessels, specifically from the knee to the ankle. All right. The techniques should use saline solution. It can be used in a way which is to messen, which is to bloat everything and then act, or in a wall technique approach, which means to instillate small amounts while you aspirate, aspirate, and you somehow sculpt little by little the whole leg with, in my opinion, much more delicacy. All right. So in my opinion, the advantage of this technique is that it's much more delicate. The complications are going to be less if you remove big volumes, because for 1 or 2 liters, everything's more or less fine. But when you remove above 2 liters, you need a more delicate technique. And also, in my opinion, it allows you to obtain a more defined or high definition results. That's what I think about this technique. And I'm not saying all, but many or most of the surgeons that only treat lipedema, they use wall technique. Of course, if you treat abdomen, etc., you use the same device for one thing or the other. But if you just treat lipedema, I would say it's increasingly getting more popular finally, because it's more delicate and more detailed.
I have quite a personal question, actually, because a person is asking, why did you choose us, meaning Lipi patients, to dedicate your career to? Why devoting yourself to lipedema? Because
I
we are
think
not comfortable patients. So why you love us so much?
you know, do you know the answer or no? You don't know
No,
the answer.
no.
Yes, Marcela knows the answer, I guess. No.
No, I
No,
don't.
no. All right. I spoke about this at a newspaper in Spain. So,
Okay.
yeah. So, a lot of years ago, my wife had lipedema, and she was not aware that there was lipedema. So we were consulting a lot of doctors and a lot of different options, and nobody would give her an answer. All right. So as I was a surgeon, a doctor, I was like, "Who's treating this in Spain?" And I was like, "There's no one devoted to this, specifically this, etc." The world technique is not really very available here. So that's why I started to jump into that world, to get to know, to learn how to use it, to train myself, and at last, and to solve my wife's problem, which is very difficult to operate someone you love. That's the thing. But I can tell you also that if you operate your wife, after that you can operate the Queen of England if you want, because there's no higher level of confidence, or there's no higher level of
Stress.
tension if you want. I was very calm, but still, now I don't know, the famous the Queen of Spain, because I have lipedema. Come on, let's do it.
I
Because
really
so
didn't
yes,
know about this,
yeah,
doctor.
no,
So
yeah, yes, I
right,
say
this
it
is a scoop
sometimes ago.
for all, because having so much, such a big personal reason. So you are a caregiver of a Lipi, and you married a Lipi
It's a
lady.
caregiver, and also it's very different to recommend something that to leave it at home. So, for example, at first we usually tell the patients to go for a shower, and if you feel a little bit dizzy, it's better to have the shower sitting on the floor. I tried that at home, and I almost killed myself. My wife was shouting at me, "What are you doing?" I was like, "No more recommendation of sitting on the floor. Just sitting in a plastic chair, and don't kill yourself." So and the pain, the emotional ups and downs, everything is like. Luckily, everything went well. She's pain-free now. We had a baby, and there has been no regrowth, so I'm very happy about that. But it was like a very tense moment to do that. But
Congratulations for the
it was
baby.
also I learned a lot from all that process from the inside. So yes, I guess I don't know many people that operated someone near to them, but I felt confident to do it, and I feel that there was the proper thing to do, and that was what I trained for many years. And at first he was reluctant. He was trying conservative treatment, improving, not that much, up downs, up downs. Finally, she was not standing the heat in Madrid, and we did it.
So any advice for caregivers?
Any
Not
of us
an
for
advice
caregivers?
for surgeon, but
Yes, I
for
would
caregivers.
say. Payback, get something in return at the end, like a trip or something, or a nice dinner. No, seriously, I guess that the the caregivers, they've been suffering with them for a long period of time, so they're usually very happy, first, that they got a diagnosis, second, that they're gonna starting to see the light. They're gonna need a lot of patience, because they're gonna have a bad not a good time, and they're not gonna be able to complain much. So as a caregiver, you cannot complain. Help with compression. Yeah, be careful. It's like, I just move a millimeter. So yes, they're crucial. They're crucial. And my message is, come to the consultation or do the online consultation together, so you can have the information first-handed, so you know what's going to be about, and a lot of patients, and at the end receive a trip or something in reward too, if possible.
Thank
Okay.
you, doctor.
Thank
I'm
you.
just saying, Manuela from andLINFA is saying, tell the doctor I loved his testimony. It was so unexpected. So thank you very much to share with us and all our followers and Lipis at home. something very personal of your family story. Thank you. This was an amazing gift that is added to all the technical and scientific details. So you put some heart in addition to the scientific thing. That is something that is very emotional to us. So thank you very much for this gift to us, all our lipids. Marcella, we're closing. It's time to close, I believe.
Yes. I mean, it's time. It's a pity. The time flies when
Yes.
something is interesting.
I'm very glad to be here, and these moments that I'm with you, I'm not changing my baby, so it's also a rest for me. So
We
it's
are an alternative to Pampers.
Congratulations for the
so
baby, and
thank
say
you.
hi to your wives that she's one of us, and now we know. So she is all our solidarity. So,
All
doctor,
right.
thank you very much for saying that.
Thank you all the ones that are watching this. It's a big fight that we all are doing about raising awareness about to uh, bearing looks from the GPs that they don't trust you. My advice is just don't hesitate to be firm and to know that to tell them that this is a condition. Print our scientific articles. Teach them, make them inform your families, inform everybody. Don't be ashamed of having lipedema, of sharing your journey. If you feel that it's too intense to share it live, go through it and then speak about it. Speak in your normal life as I had a liposuction for lipedema, and that's it. Because the thing is that when you have a gallbladder problem and you have an operation for the gallbladder, nobody questions you and nobody tells you anything. But with liposuction, everybody starts to feel that there's aesthetics and there's something. She's doing it just for no. It's good also to be very serious about it. So when somebody asks you and you inform, do it seriously. Like, this is a serious thing. So explain it, but with firmness. This is a condition. If you don't know it, I can explain it to you, but it's not that my problem that you don't know it. All right. So my advice is not to feel ashamed. Speak about it freely with your friends, with your family, with the GP, and we. Fortunately, in Spain, all the patients get sick leave. They don't. They cannot work because we inform. We with a written report that this has been done for medical reasons, which is the truth. All right, and also for the international patients, usually this is enough. And I think this, with initiatives as yours and Lipedema UK, as everybody, the speaking about this as a medical condition, it's going to change all this, and it's going to, at the end, going to make the situation very different for all the affected women.
Thank you, doctor, for
Thank you.
telling and stating this loud and clear, because lipedema is a disease and must be treated as a disease. It's not a cosmetic condition. It's not something we can live with without treatment. It's something that must raise all the attentions from clinicians, because we need to be well treated as every people who has a very problematic and hard disease. Thank you very much, doctor.
All right. Okay. It was a pleasure. See you next time.
Okay,
Yes.
let's give. We will have next webinar, our last one, next week on the 20th of July. Let's next Wednesday, I believe.
Yes.
And we will have Dr. Michelini speaking about, from Italy, so speaking about future plans in lipedema. We have super plans in lipedema. And also all the three associations, we LIO Lipedema Italia, andLINFA from Portugal, and Lipedema UK, will present the manifesto of lipedema patient associations to advocate together, because we state that together we are stronger, and we want to advocate together to have a better future for our lipedema patients. Thank you, doctor, again. Thank you, Marcella.
Thank you. Thank you, Valeria. Thank you,
Thank you,
doctor.
Maria
It
Marcela.
was a
See you.
pleasure to meet you
My
again.
pleasure.
Hasta
Bye-bye.
luego.
Adios.
Adios.
Adios.